Yeah, this is the free weekly webinar series that we've been doing every Tuesday and Thursday, hopefully to help you feel better about starting your surgical on calls. So just at 1 minute past 7, so we can start. So today's speaker is Dr. Alice Gargan. She's one of the committee members of NSTS and has been with us from the start. She's recently, she's an FY2, but she's recently secured a plastic surgery themed core surgical training job, phenomenally becoming 38th in the country in rankings at St George's in London, which will be starting in October. She's really keen about surgical education, and she's actually on a branch of the committee at the moment that's helping with the virtual theatre curriculum, and that will be coming out in September, so stay tuned. I had the pleasure of going to university with Alice, and I know she's about to deliver a fantastic lecture. So without further ado, I'm going to hand it over to Alice.
Hello, can you hear me? Yeah. So yeah, my name's Alice. Thank you, Jen, for the introduction. Today, I've clicked too many buttons, but we're going to go through a few, as with all the other lectures, common on-call scenario bleeps that all of you, I think most of you are about to become F1s. So how you'd approach the patient with a high temperature, including recognizing sepsis, a patient with low blood pressure, and a patient with confusion. So 3 common bleeps that you might get when you're an F1. So hopefully you feel a bit more confident at the end of this. Feel free to put questions in the chat the whole way through. Jen's going to be monitoring it. It's a really sunny day, so thank you all for turning up. Hopefully we'll be done before 8 o'clock, so you can all enjoy the rest of your evenings. So, first of all, you've been bleeped, and this is you with your FY1 badge on. Doctor, one of your patients has a temperature, so don't panic, it says it on all the slides. Scenario number 1, so 65-year-old male, he's spiked a temperature of 38. So this is a temperature. It's always worth checking with the nurse on the phone if he's actually spiked a temperature or not, because sometimes they haven't. Most nurses will have given them paracetamol or tried to anyway, but if not, it's always worth, you can check that they've got paracetamol prescribed, and then you can ask them to give some paracetamol before you even get there. But what else will you be thinking when you're on the phone? What else do you need to find out? If you're at a hospital that's lucky enough to have virtual notes, you can ask for the patient's hospital number, have a look at their notes. You can see their observations throughout the day, have a little look at whether how many days post-op they are, have they got paracetamol prescribed already? If so, the nurse can give it. Obviously, if you haven't got electronic notes, you need to go to the ward anyway to take a look. So as a practical point, blood bottles, blood culture sets can actually be really difficult to find when you're on call if you're traipsing around a really big hospital. I used to know a cupboard in like an opposite wing. It was the only place I knew that had blood cultures. So if I had to find them myself, then I had to go there before the ward. So it's useful to ask the nurse to get an up-to-date set of observations and a blood culture set ready for you. So as you're heading over to the patient, you can kind of be thinking about differentials in your head. So have they had recent surgery? If you're the surgical F1 on call, most likely they have had recent surgery or they're going to be having surgery. What drugs might they be on? So drugs such as, have they had a recent blood transfusion that might have caused their temperature to spike? I'm going to be thinking about antibiotics as well. How many doses have they had? Is it doing its job? Obviously, with a temperature, your first thought is usually, well, my first thought is, have they got an infection brewing? Are they hemodynamically stable? So this is where you start thinking when you're prioritizing your patients on call. How sick is this person? How quickly do you need to go see them? Have they just spiked a little temperature? Are they already on the right treatment, or are they really unwell? So linked onto this, is this serious? Is it, think of your prioritizing. How quickly do you need to see this patient? And so you're starting to think about things as you're walking over. So here you are. You're tired already, apparently, and you've asked all the important questions. You're on the way for the ward, and always ask for a full set of observations to be repeated before you go, and check the thermometer's working, because sometimes it's not. So this is where going to see the patient is the most important thing, because does this patient have a temperature that's worrying or not? And that's what you need to figure out when you're on call by yourself. So this man, he's a 65-year-old man. He's 2 days post-op, for peptic ulcer emergency repair. You have a look at his notes and you notice that on the ward round that morning, they've already suspected he's developed a chest infection and he's been started on antibiotics. So you're looking at him, you do your A to E. Here you go, these are his observations. So he's got a temperature, 37.6. Otherwise, he's pretty stable. He's not started decompensating like hemodynamically. His heart rate's 85. His blood pressure is still 135 over 80. He's saturating well, but at the end of the bed, he looks a bit sweaty. So you might be thinking here, oh, this temperature might be appropriate for the fact that he's already developed a chest infection. He's probably on the right treatment. He might not have had many doses of his antibiotics yet. So what can you do in order just to reassure him and obviously you do your full assessment, but you might not actually need to intervene for this patient. However, scenario number 2. So this time you've got a 65-year-old male, he's 7 days post-op for the same operation, and you're walking into the ward and you don't even need to, before even starting your A to E examination, you just think he looks horrendous. And that's one thing that you develop really well throughout your first year, is just being able to see a patient. Do they look ill or do they not look ill? Sick or not sick? It's the most important thing to figure out. So this guy, you do the AT examination, which I'm not going to talk through because you're all final year medical students, you know what to do. His temperature is 38.4. Otherwise, looking at his observations, so he's slightly borderline tachycardic, 104, but he's also dropped his blood pressure, 80 over 40. For a 65-year-old male, that's definitely low. So this patient you're already worried about. He's starting to decompensate in other ways, not just the temperature. So I'll give you a second to think about your differentials. So there's your second. When a patient has a temperature, obviously most people go straight for the infective cause and I mean, it can be a wound. The patient's had an operation, he's got a wound site, might have developed a collection. Obviously chest and urine, the most common sources for post-op infection. But you need to also think about it. So I always think about, when I see a patient with a temperature, infective and non-infective causes. People obviously categorize them in their own way, but I find this is the most logical way to do it. So they might have developed atelectasis, they might have a PE or a DVT, and depending on how close they are, like a drug reaction might have been a anaphylactic reaction. They could have had a reaction to anesthetics if it's the anesthetic, if it's near the end of the operation, or they might have had a recent blood transfusion. So infective and non-infective causes. So this is a format I think has been used in most of the lectures of this series, but it's really useful in real life as a way of thinking through things. So what you can do at the bedside, so that's your A to E, your observations. What bloods are you thinking about taking? What imaging might you want? And then probably less relevant when you're the surgical F1 on call, but special tests that are going to help you with the diagnosis. So let's say in this 65-year-old male, both of them, that it's an infective cause. So we're thinking about you as the F1 on call, what are you going to do? And that's going to be your sepsis 6. So I think of this as buffalo, but that's just because it's how I was taught at university. And when you're panicking, it's, I mean, the letters lay out, you can remember them from the letters as opposed to trying to remember the sepsis 6 when you're panicking. So they're the exact same thing though. So do it the way you know how, but you've got your 6 things that you need to do, 3 in, 3 out. You've got blood cultures, urine output. Has it been tapering off throughout the day? Have they got no urine output? Have they got fluids prescribed? You're going to be thinking about giving them a bolus. We'll go into that with management. What antibiotics do they need? What's their lactate? And start them on oxygen if you're worried about them. So the sepsis 6 or buffalo are all things that you can initiate as the F1. Even if the patient's really sick and you think you need senior help quickly, you should be able to do all of these, and you should feel confident in being able to do all of these things. Sometimes septic patients are really difficult to bleed, so never feel bad about having to ask somebody else to come and give you a hand, even if you're SHO or something. So initial management for patient infective cause of high temperature. So in that first scenario, you do your A to E assessment. Now, they identified on the ward round that this patient they thought had a chest infection. he's had a couple of doses. So say you're the evening or the night F1, he's had a couple of doses of his antibiotics now. So you can have a listen to his chest. Do you agree? Have a look at his chest x-ray. Has he been started on the right antibiotics? You can definitely send a repeat set of bloods and some repeat cultures, which will be useful for the day team. But if you're happy that he's on the right antibiotics, you think he's fairly stable, then you can just document that you've assessed him, you've identified he had a temperature, you've seen the patient, but you're happy that he's on the right management. So that would be for the patient we were less worried about. However, the second patient, he was sick. I mean, you saw that he looked sick from the end of the bed. So you're going to do your A to E assessment that you all know, your buffalo. This patient, so as I said, the buffalo, they are the 6 things that you can do as the F1, and you look really slick if the patient's really, really deteriorating, then of course you can escalate very quickly. You can put out a medical emergency call. But if the patient's septic, he's doing okay, he's chatting to you, you can get started on this buffalo sepsis 6, and then you can escalate to your registrar. If you ring your registrar going, look, I've taken some blood cultures, I've sent off a lactate, I've done a VBG, I know the lactate, I've given him a fluid bolus, and he's on oxygen. What do you want me to do now? Or can you come and see the patient with me? I'm still worried about them. Then you just look great that you've already done those 6 things, because otherwise you're going to ring your registrar and go, there's a patient with a temperature, he looks really unwell, what do I do? And they'll tell you to do the sepsis 6. So if you've started initiating it first, you just look quite competent. This patient's sick, so you're definitely going to be thinking about handing over to the night team for a review. And again, document clearly. That's obviously good practice for everything. This is from Teach Me Surgery website that, if you haven't come across, is really useful way to think about where, it's not Bible, what each day post-op is the infection will be, but it's quite a good indication. So day 1, 2, you can post-op, considering a respiratory source. So the patient's in pain, they're not taking deep enough breaths properly. So they're not aerating the bottom of their lungs very well. And so they're really high risk of getting a respiratory infection. Day 3, 5, more likely a urinary source, and later on, more likely an abscess, because it takes a bit of time to form a collection, which is going to mount a temperature. Or a surgical site infection. So you want to look at that wound, even though the nurse says they've only just redressed it, you need to have a look at it yourself. Of course, consider all lines, including cannulas, as a possible source at any day. So antibiotics in the sepsis 6 or buffalo. I'm not going to list off antibiotics for you because you'll all be revising it for your finals, or you've passed. Congratulations if you've all passed. And you will have trust guidelines. So it will be different throughout the country. What's the first line for chest infection, urine infections? So the most important thing is to know where your hospital guidelines are. There's always a microbiologist on call that you can speak to, but usually if it's a simple chest infection, it's detailed in the guidelines. You don't even need to speak to them. If you are worried about that patient that you've given 2 doses to and you don't think it's working, then that's what they're really useful for, considering another source or telling you to send off a few atypical screens, etc. And they're usually available via Switch, or if you haven't downloaded it already and you're starting your job in August, this isn't an ad. The induction app I use every day at work is brilliant. You can set it to this was my hospital last year, St. Mary's. You can set it to your hospital, and it means you can call directly from your phone. You don't need to find a phone. If you get bleeped, you can also call through your phone as opposed to finding a phone. So if you've nipped Costa, you can return a bleep easily. So definitely download the induction app if you're starting in August. But usually most things are covered pretty well on the treatment guidelines, except for there's some specific things like orbital cellulitis, etc. That's when you always speak to the microbiologist. So always check allergies. And if your patient's still spiking, as we covered, after a few doses of antibiotics, you need to review it, the source, and another cause of the pyrexia. Okay, Jen, are there any questions from the first case? For most people, I think that's probably one that's quite well managed.
Yeah, absolutely. I'll just hang on to see if any questions. There was one question just about talking about different causes of fever, as to what drugs can cause fever.
So yeah, I mean, it's a difficult one. There's Obviously, blood transfusion is really common for a patient to develop a fever. It doesn't immediately mean you need to stop the transfusion. You might just need to slow it down and give them some fluids. Any drug allergy usually causes an inflammatory response, and you get fever associated with that. Some painkillers can cause patients to develop a fever. Obviously not paracetamol. Paracetamol helps that. And then the side effects of some drugs. So for example, if you have a patient who's taken a lot of codeine, they might become constipated. Constipation can cause a fever. And I think some anesthetics can as well, Jen.
Yes, I think post general anaesthetic after you've had, I think you mentioned in your time frame, and also I think I've had a patient actually quite interestingly that developed a fever after having antibiotics just because it made them feel a bit funny, which is a bit counterintuitive. But yeah, some people react funny to different, especially IVs. So yeah, thank you for that. That was all so far. We'll keep going unless anybody else has got any questions.
Yeah. So
carry on.
Pardon?
Just saying thanks.
Okay, perfect. Yeah, no, the drug ones almost is something you need to think about later on if the patient doesn't have a clear sign of infection or doesn't have a VTE. It's just another thing to think about. So another scenario. The F1 looks like he's panicking again, but don't panic. You get bleeped by a nurse. Doctor, this patient's got a blood pressure of 80/50. So I got bleeped about that on my first day, and I was like, oh no, that sounds disastrous. And so I did panic. But there we go. We'll just bring it back to, again, how we went through the first one. So what else do you need to find out? So again, really useful if you've got electronic notes, you can put the patient's number in and have a little quick read. If the nurse is really worried, it's often useful to go and have a look at them first. So when they look, whether they look unwell. And that, again, I'll reiterate that again, it was taught to me by Ortho Reg again, just look at the patient, sick or not sick. And that's a very good way of how to prioritize things when on call. So, of course, you're thinking, when did they come into hospital? Are they post-op, or they might be pre-op? Do they look unwell, and where are you going? So yeah, phew, he's feeling a bit better already because he's thought about all these things. You've asked all the important questions, and you're now on your way to the ward. You obviously will ask the nurse to do a full set of observations whilst you're on your way. So again, what are your initial thoughts as you're going to see this patient? You've got a patient with a low blood pressure. What could you be thinking about? Have they had recent surgery? Was it that morning? Have they been in hospital for a while? Have they been nil by mouth? Have they been prescribed their maintenance fluids by the day team? Or has this poor patient been nil by mouth all day, missed his operation, not drunk anything, and then the day team have forgotten to prescribe him any fluids? So coming on to that, are they hemodynamically stable? We touched on that in the first one. Have they mounted a tachycardia to make up for this, or do they sit quite happily at 80/50? Urine output is a really, really important one for lots of things, especially blood pressure, because it gives you an idea about end organ perfusion. Is the blood pressure so low that the kidneys are drying out a bit, and so they're not actually producing any urine? What's their normal blood pressure? Be careful with this one, because patients can be on medications that alter this. Patients on beta blockers sometimes don't mount more so a tachycardia when they're sick, and sometimes people are like, oh, yeah, they usually sit around that, but actually they could be bleeding. So that one's one, we are going to touch on it in this scenario, but that is one to be wary of in real life. And again, end organ perfusion, are they alert? Are they chatting? Is their GCS 15/15, or have they started to become more confused? So your first scenario is a 59-year-old male. His blood pressure is 80/50. Let's say he's post-op for a hernia repair. He's confused. He's got a low urine output and he looks unwell. So of course you've gone to see him. I mean, you can see from this before you've even done your assessment, he looks sick. So you do your A to E, and his obs are heart rate 117, blood pressure 80/50, saturating fine on room air, but he looks confused. I mean, you don't know what he's like at baseline, but he looks confused, and he's apyrexial. So you're a bit worried about this chap because he's not only hypotensive, he's also tachycardic now. Whereas, say in the bed next door, you've got a 19-year-old female, her blood pressure is also 80/50. She's got a normal urine output. It seems like her blood pressure has been 80 over 50. I know I said to be wary, but it's been like this the whole of her admission, and no one else has seemed to have done anything about it. She's on lots of analgesia post-op for her appendicectomy, and her GCS is 15 out of 50. So when you're looking at this girl from the end of the bed, when you're doing before you do your AT examination, so her heart rate is 60, her blood pressure is 80 over 50. She's saturating beautifully on room air. She's apyrexial, and she's absolutely chilling, sat watching some TikToks on her phone. So you can tell these two scenarios are just completely different from looking at the patient at the end of the bed and doing some observations. It's going to completely change how you're going to manage and prioritize when on call. So differentials for a low blood pressure. I'll let you all have a 10-second think about what you might think. Okay, so differentials. Again, infection's always up there at the top. Have they got an infection? Are they in septic shock? Have they had a drug reaction? Anaphylactic can cause you to have a profoundly low blood pressure. Are they bleeding? They've had an operation. They could have come back from theatre. They could be leaking, and that's causing their blood pressure to drop. Other kinds of shock, cardiogenic shock, neurogenic shock, and could it be a normal variant for that patient? If she's got a good urine output, normal GCS, then it's far less concerning. Okay, so again, we touched on this, and it might seem a bit repetitive, but this has got me out of a lot of jams at work, just going through your systematic approach. So you're at the bedside, that's your A to E assessment, your observations. With a low blood pressure, you want to see what their heart rate's doing as well. So whether they've mounted a tachycardia, you want to do an ECG and a urine dip. Full blood count, use and ease, LFTs, coag, group and save, and a lactate. You can get the quickest way to get a lactate for your septic patient or your low blood pressure is VBG, but you can send off a formal one as well. Imaging, thinking about chest x-ray, ultrasound, maybe less so in this one. And if your patient, so say post-op abdomen, do they have a collection that's causing them to become septic? Do they need a CTAP, or are they bleeding? This is where you're going to be getting senior input down here. So initial management for a patient with low blood pressure. Back to the basics again. Is that patient well or unwell? Do your A to E, look at the observations and their input-output chart. Are you worried about this patient? That lady, that 19-year-old sat chilling on a phone, watching TikToks. I don't think you're very worried about her. Maybe tell her to have a drink and then see what it does, have a walk around. Is she okay? Or you're not too worried. Whereas that other gentleman, he's unwell. He's going to need some kind of fluid resuscitation and intervention. So low blood pressure, give fluids. I always ask the nurses to encourage oral intake. It's on everybody's plan when you're an F1. So you can give fluids, oral or IV. 500 ml bolus, normal saline. You are not going to go wrong doing that in anyone, really. Maybe a very fragile elderly lady with really fragile heart failure, you give the 250 bolus, but realistically in real life, a 500 ml bolus is the same as putting someone's feet in the air in terms of venous return. And someone said to me once, it's basically a can of Diet Coke, and you probably aren't going to kill a lot of people with a can of Diet Coke. So 500 ml bolus, normal saline, and then importantly is monitoring their response to that. So did the blood pressure improve? So those we call a responder. Did the blood pressure improve, then immediately fall again, a transient responder? Or did the blood pressure stay the same or in fact get worse, a non-responder? So think about how we'd manage each of those. So the responder, brilliant. You've given them a 500 ml bolus. Their blood pressure's come up to 130 over 70. And so most likely they're dry. Perhaps the day team forgot to prescribe their maintenance fluid. Perhaps they were nil by mouth for a really long period. Perhaps they've gone off their food. There's all sorts of reasons. Patients are really dry post-op commonly. So the best thing to do for this patient, you know that they're responding to fluids, prescribe them some maintenance fluids, encourage oral intake unless they're nil by mouth, and then get the nurses to call you back if it drops or there's any further concerns. And obviously document what you've done. You've seen the patient, you've intervened. Then the transient responder. So you can give another bolus and then check again because their blood pressure did pick up a bit. It might be that they're really, really dry and they just need some more fluid. If it's still transient, you want to think of other causes, so maybe bleeding. So if you think of the patient as a bathtub with the plug is open, if you can keep filling up the patient with 500 mils, but if they're leaking from somewhere, it's going to not really do much. That needs fixing. And if they're really septic, it might be that everything you're putting into the intravascular space, they've got leaky vessels and it's just going straight out into the extravasating. So they might need those are the people that might need circulatory support. So you probably wouldn't be speaking to ITU as the F1. So those people, have a chat to your reg or your SHO. They might need some input from seniors. Then you're a non-responder. So if someone's absolutely not responded, their blood pressure's still tanking, then they're the ones that you should be immediately escalating, especially if it's that patient you're worried about. So any questions from that one, Jen?
Yes, we do have a couple of questions about fluids. So 2 are quite similar in the sense of how soon after you give that bolus are you measuring the BP again to determine whether they respond to it? And similar, you know, when would you expect a response to have happened, and what are you thinking at the point when they're not responding?
Yeah, so a response to a fluid bolus should be pretty instantaneous. I mean, usually it goes in, they say stat, but it usually takes like 15 minutes for 500 mils to go through. So then you're just going to check it after that. As soon as the fluid's in, it should have taken an effect. The quickest way to see if someone is a responder is to lift their legs up into the air and check their blood pressure straight away. But lots of old ladies don't like their legs being lifted in the air, so it's quicker to give them a 500 ml bolus.
Yeah, no, that's fair enough. I guess if you're worried that their blood pressure's dropping, serial blood pressures are good. You want to bring a nurse in with you along by the bedside so that you can see which way it's going.
You can put them on your OBS machine, and most of them have us circulating like every 5-10 minutes, depending on how worried you are.
Absolutely. Someone's just asked, I think it was a bit speedy for them, could you quickly flip back to the differential slides? We could just flip back to that while we're discussing other questions. So
that's our differentials.
Yeah, loads of really useful causes and information there, so that's useful. Someone mentioned about, would you mind explaining a little bit more about the intravascular interstitial spaces? Just briefly, just really simply for somebody who never quite got it, which is understandable.
Yeah, no, I mean, this is something that I've struggled with at university as well. I wasn't that interested in where fluid was, but it actually is quite important. So the reason we check for like peripheral edema is if the fluid is pooling in someone's ankles, that just is a clinical sign that the fluid is not in the right place. If the fluid is not in your blood vessel, then that's why you've got a low blood pressure. And those people, so there's different causes for fluid going out, and I'm not going to go into like osmotic movement because it's really boring and you don't want to do surgery, you should go to ITU. Septic patients get really leaky blood vessels. So when you give them fluids, it just kind of leaves the blood vessels, and therefore it's sitting in the extravascular space. So that's why you can feel it as edema. I'm like checking my own edema at the same time, but I don't have any, it's fine. That's why these patients need vasopressors, because that stops the blood vessels being leaky, and then that keeps all the fluid in the right compartment. Same happens with anaphylaxis. Bleeding is because there's an actual source of bleeding, so that's why it's leaving by itself. And I think that's basically all the detail you need it to be in. Is the fluid in the right place? Is it in the blood vessel, or is it out of the blood vessel? If it's out of the blood vessel, how do we get it in? And that's either by a vasopressor, most commonly, or fixing the source.
Absolutely, just really useful to know that, thinking to how to treat it. So that was very good, thank you. And if you want to go into more detail, I recommend looking up like YouTube videos on how it works. They're very useful. Thanks, that's fab. The other one is again, slightly more complicated, but last one on fluids for questions for now. It basically is talking about medications that you could give for hypotension in a specific scenario. So basically, if a patient has AKI and pulmonary edema, but their BP is dropping rapidly and you don't want to exacerbate it, would you give flucortisone or midodrine?
So a sick patient with pulmonary edema and AKI. So
Yes.
you're doing an A to E assessment and you've come across pulmonary edema in your B. Your patient is sick. Correct me if I'm wrong, Jen. Your patient is sick. You worry about the kidneys later. You give that patient furosemide to stop them dying from their respiratory condition. The patient's going to, rather they not drown to death from having fluid on their lungs and then worry about their AKI later, than have pristine kidneys and be dead because they died of pulmonary edema.
I think what I would say to this question is that these are definitely kind of big worries and things that you think manage. But if you're ever trying to manage or do this balancing act, you're going to want to be getting help from seniors to make this decision.
Yeah, definitely.
That
was one of the worst things as an F1 is changing someone's furosemide dose when you're looking at their potassium, and you just change it every day depending on how bad their potassium is and how bad their breathing is. But it's not something, you wouldn't be managing pulmonary edema by yourself out of hours. And if that patient was sick, it's likely they're going to need to go to ITU, and then they'll get their furosemide, but they'll also be put on a filter to save their kidneys. But in the acute scenario as an F1, if you were worried that a patient has pulmonary edema and you had no help on the way, you wouldn't be in trouble for giving a 40 milligram bolus of furosemide.
Yeah, absolutely. One more about neurogenic shock. What do you do about a patient with a low BP if it's for neurogenic shock? So I guess this is kind of as well going into slightly more less medically related scenarios, but I appreciate these are relevant to kind of low urine output.
If you've diagnosed a neurogenic shock, I'd be extremely impressed as an F1. They kind of tend to be in distributive shock and their heart rate doesn't mount as well. It's like a sympathetic outflow issue. And those are the patients that will need some kind of circulatory support, and you'll definitely be discussing them with a senior. You wouldn't be managing them by yourself.
This is where you'd probably be getting critical care outreach or ITU involved if you're worried that someone's really shutting down and hasn't got a urine output or is showing signs of neurogenic shock and they're low BP. This is where you're calling for help, is basically my simple answer. Is that okay? Should we move on to the next scenario? We can come back to it at the end if we want to discuss it in more detail.
Oh, yeah. So, you're panicking again because you think you've just diagnosed a neurogenic shock and critical care outreach aren't on the way, but you've given your fluid bolus and now you've got a bleep. Doctor, this patient seems a bit confused. This is one of my least favorite bleeps to get as an F1 because it was so vague. So back to the start, what else do you need to find out? So what did they come in with? Are they post-op, pre-op? What are they being treated for? You again can have a look on your e-notes if you have them and have a little read through before you go. But then you're heading over. You've asked all the important questions and you're on your way to the ward. For confusion, it'd be really useful to get an up-to-date set of observations anyway. So you can ask the nurse to do that while you're on your way. So here's your scenario 3. Got a 79-year-old male. He's 12 hours post a complicated hemiarthroplasty. It was a much longer operation than expected. He's shouting at the nurses. He's trying to leave the ward. He's trying to pull his catheter out. He seems really upset and he's really confused. And what's really useful is the nurses are with your patients all day. They have a much better idea about the baseline of your patients than you do just because you spend less time with them. The nurses tell you this is completely out of character for him. He was doing his crossword this morning, chatting away to the man in the bed next to him. So they're really worried about what's going on. So initial thoughts. Surgeons love ordered thinking. So here's a pinch me for confusion that's really useful. The surgical sieve, if you haven't heard of the surgical sieve, it's a way to think about differentials for every presentation you have, like vitamin A, B, C, D, E. You can just Google them. There's loads and loads of different ones and find the one that works for you. So pain. Patients have had an operation. They're bound to be in pain. If they haven't got appropriate analgesia, this can definitely cause confusion. Infection comes up time and time again. If you're infected, you could have a low blood pressure, which is causing a low brain perfusion, which could be causing your confusion. Infection is one of the most common causes, UTIs for confusion in the elderly, acute delirium. So it's definitely got to be top of your differentials. Nutrition, not really going to go into this, but it has been shown that malnutrition can increase the risk of post-op delirium. Constipation, really, really common in your post-op patients. It puts a lot of stress on the body, and the body tends to slow down a little bit in terms of gut transit. So that can, if patients are bunged up and not on appropriate laxatives, they can become constipated. And urine retention. Most common cause of a low urine output post-op is a blocked catheter, which could cause a patient to go into urinary retention. This patient that we've seen in the scenario, he's tugging at his catheter. Has it been draining? Have a look. It might be that it's blocked. He's in acute retention and he's really confused and upset. Who wouldn't be? Hydration. Again, we've obviously touched on this in the last scenario. Low blood pressure. Have they been prescribed appropriate maintenance fluids? Are they drinking enough post-op? Is that what's causing them a low blood pressure and low end organ perfusion and causing them to be confused? Medications, again, so opioid toxicity, that can cause you to be confused, and lots of anesthesias can as well. You get all sorts. And finally, you want to be checking those electrolytes. Any kind of abnormality in electrolytes can manifest itself as confusion and easily corrected. So again, going through our what you're going to do at the bedside as the F1. So your A to E assessment, set of observations, ECG and a urine dip. You can see if the patient's infected. Do bloods, full blood count, use NEEs, LFTs, coag, group and save, and a lactate. Lactate again would point you towards maybe an intra-abdominal source or an infection. If you think your patient's confused, might need a chest x-ray, ultrasound. This would be worth chatting to the nurses. Has he sustained an injury? Perhaps he needs a CT head. Maybe he had a fall on the ward, and if he, especially if he was on anticoagulants, then he could have a bleed, which could be causing his confusion. So going through these is a good way. And finally, yeah, your CT abdomen, oh, and as I've mentioned, your CT head. So confused patients can be really difficult to manage, and it's actually not their fault, and it's very easy to become quite annoyed with them, but most of the time they have a reason to be confused and agitated and upset, and it's quite tricky. You can work with the nurses to see what you can do. So back to the basics, look at your patient. Are they well or unwell? It might be that the patient's just got known dementia and he does this every night. And in fact, if you chat to him, get his daughter on the phone, then he settles down and he's very calm. So it's useful to speak to the nurses about his patient baseline. But it might be that he's really, really sick. He's got a new infection and you need to resuscitate and intervene. So yeah, you're going to be investigating those organic causes and correcting them as possible. So thinking through your pinch me and managing them as appropriate, that I'm sure you're all able to do as fifth years. So yeah, for the confused patient, if possible, trying to get family members on the phone is really good, because it's nice. It orientates patients, even if it's an organic cause for their delirium, kind of settles them down, and it means that you're able to get that cannula in to give them some antibiotics, means you're able to get the urine dip or flush their catheter. Do avoid using further sedation, because sometimes it's unavoidable because of risk to staff and other patients and the patient themselves. If he's at a risk of, for example, on ITU, we had a patient who was really, really confused. This was in COVID actually, and he was on Optiflow, which is kind of like CPAP, but just with a nasal cannula. And he had intensive care delirium. He was trying to get up, pulling his cannulas out, trying to pull the oxygen off. And because he kept pulling his oxygen off, his saturations with COVID were going down to 60, 50. It was really dangerous. So we had to use a bit of sedation to get him to keep his oxygen on. But on the ward, it's good practice to try and do everything you can first before sedating somebody. And of course, escalate if concerned, not only to your SHO, your registrar, but if you're worried about the safety of a patient or other patients, you can speak to the on-site security team, who are really useful in these kind of scenarios. But the management, do your A to E first, go back to the basics, your observations, think about causes, and then just being safe and documenting. So, there we go. Well, we've come to the, let's do the questions for that one first, Jen. And that was our last scenario. Jen?
Sorry, I was just muted and talking away to myself. Sorry about that, everybody. So the first question is, for confusion, is how can constipation cause urinary retention?
Oh, so constipation, for this slide, I actually meant constipation can cause confusion, and because kind of bowel and bladder are nearby, urinary retention can also cause confusion, but constipation can actually cause urinary retention. If you've got a patient that's so fecally loaded, they can cause a pressure on the bladder, and it can cause like a post-obstructive pattern so that the urine can't get out. If a patient's that constipated, it actually can happen.
Yeah, very good. Yeah, I just thought I'd turn on my video as well. But yeah, definitely can, very common actually, a cause of urinary retention. So for urology as well, always good to do a DRE. If you've got somebody in urinary retention, worry about things like prostate, yeah, post-renal causes. Fantastic. There's a question here just briefly to speak for what is included in a confusion screen.
So yeah, confusion screen is usually, it's less so done on a, I think it's less done on a surgical ward, but it's confusion screen includes checking all your electrolytes, checking someone's thyroid function, checking their hematinics, so their B12 and folate, and actually doing a syphilis screen as well. I guess your full blood count would be included, but I guess they'll usually have that every day anyway, but that's your main confusion screen.
Yeah, I guess anything that investigates the causes that we've looked into. Fantastic. Yeah. Thank you. Is there any difference between confusion and delirium?
I guess confusion is the symptom, and delirium is one of the causes of confusion. It's kind of, I guess I've used it a little bit interchangeably there, probably incorrectly. Confusion's the symptom, delirium is one of the causes of it.
Absolutely agree. So I'm just joining in with all of these questions now, but yeah,
I love it, don't worry.
delirium sometimes it's called acute confusional state as well. So they are sometimes used interchangeably. But yeah, delirium tends to be an acute thing, which is amazing. Thank you. Yep, that's very clear. Continue to ask questions as well, guys, if you want on this as we go along. This next question is just, do you need to involve a senior if you wish to sedate someone?
This comes down to your experience. Every drug that you prescribe and give, you need to be comfortable prescribing and giving that drug. So if you've never given a diazepam or a lorazepam or a haloperidol before, then it would be completely within your right to ask your senior, because if something goes wrong, for example, you give too much of a benzo and your patient kind of conks out a bit, then you need to, I think it's just work within your own competence always, and you can always ask for senior help. I don't think I would have sedated someone in my first couple of months without senior help. If a patient is known to get a bit aggressive, this is a really tricky one in terms of sedating. Sometimes we had a patient that would always get aggressive at the same time every night, and they'd have a little bit of haloperidol before bed, and the nurses knew about it and it was on the PRN, then I'd be much more likely to kind of authorize it, as opposed to a new delirium that you think there might be something else going on.
Yeah, I think that's a really good answer. Really would reiterate, just only ever prescribe what you feel confident prescribing. Don't just feel like you have to prescribe something. We have a prescribing lecture coming up, which will cover this.
I was going to say, I think we'll be covered in the prescribing lecture, but you get an awful lot of the time as an F1, you get asked to prescribe things, and just be wary that it's your name you're signing against that. So if you're not comfortable, you need to just have a quick check.
And there's normally a hospital guideline on safe sedation as well. But to answer the question bluntly, I would always involve a senior if I'm sedating anyone, is basically where I'd go. I just want, even if they're not a senior, I'd just discuss it with somebody who's more experienced than me. Is probably the safest thing to do if you're not sure. Fabulous. I mean, sorry,
there might be some other questions. In summary, we've covered how to approach the pyrexial, the hypotensive, and the confused patient as the FY1 out of hours. We've covered a structured approach for assessing, investigating, and managing these patients. And by achieving these, we've hopefully increased your confidence so you feel better prepared to go on to be the best F1s in August. And then I guess I'll give you opportunity for any general questions. So, I mean, if you missed the intro, I'm in London as an F2. I'm doing CST in October. So if anyone has any lecture related or general questions, I'm happy to answer any if you give me an email. I believe you need to follow this QR code for your feedback, and feedback for me, which would be really appreciated, and a certificate. Were there any other general questions? Let me know, Jen, if they come through. But
I will do if they come through. I'll just have a look on the things, but yeah, just thank you so much, Alice, for that lecture. Really, really concise and useful scenarios that you'll get called to time and time again. So really good to have a framework. Just to reiterate that all of our webinars will be posted on our website, which is, you can just type in National Surgical Teaching Society into Google, or follow the website which we've posted on the chat. So they all get uploaded to here, so you can go back and have a look back at the slides. As I say, it's a really, really useful thing for Alice to have the feedback for her portfolio, but also it's super useful for us to know what you find useful and what you'd like to hear in the future from further webinars. So just 5 minutes of your time or less than, it's so useful for us all to know how you find this lecture series and what's going on. The next upcoming lectures will be on Thursday. Again, that's looking at some other scenarios. But if you've got anything else that you guys would really like to be covered as things go on, just either type it here or let us know on your feedback, and we can try and fit that in at some point in the series for you. Yeah. I'll just have a quick look.
And thanks everyone for tuning in on your Tuesday evening. Tuesday? I've lost track.
Absolutely. Someone just asked, can you quickly share the slide of the management of the confusion investigation?
Yeah, of course.
But all of these slides will be available online, so don't worry if you feel like you've missed things at all.
Okay. So we'll give everyone a minute. I'll put it back on the feedback slide for a minute, and then we'll let you all go off and my email if anyone wants it. And then everyone can go and enjoy their evenings. Let me see the chat. I'll put my email in the chat. 80. Perfect. I think that just looking through the questions, I can see them now. They're fine. Okay. So thanks, everyone. I'll go away.
Thanks very much, Alice.